This lecture will go over Chapter 24, Care of Patients with Peripheral Nerve and Degenerative Neurologic Disorders. Parkinson's disease is considered a major health problem due to its crippling effects. It is a progressive disorder, beginning rapidly at first and then advancing more slowly. The term Parkinsonism is used to describe a clinical syndrome consisting of any combination of the following symptoms: bradykinesia, rest tremor, rigidity, and postural instability. The specific cause of PD is unknown, but it involves degeneration of the dopamine-producing neurons in the substantia nigra of the midbrain and the presence of Lewy bodies. The most common type of PD is idiopathic. That is, the primary or specific cause is not known. Secondary PD can be drug-induced, especially by reserpine-type antihypertensives like methyl-dopa, phenothiazines, and some tranquilizers like Haldol, some antiemetics, methamphetamine, and a few other drugs. PD affects the extrapyramidal symptom, particularly the motor structures in the basal ganglia. This is part of the brain that controls balance and coordination. Stimulation of the basal ganglia causes muscle tone in the body to be inhibited and allows for refined voluntary movements. Two neurotransmitters accomplish this action: dopamine and acetylcholine. The excessive excitation of neurons prevents a person from controlling or initiating voluntary movements. The onset of PD is gradual and may involve only one side of the body initially. A triad of symptoms is characteristic of PD, including tremor, bradykinesia, and rigidity. The first tremor occurs when the body is at rest, decreases when there is voluntary movement, and is absent when the patient is asleep. When the patient experiences stress and emotional tension, the tremor becomes more pronounced. Bradykinesia is a condition that causes slow movement and speech. The third symptom is rigidity, affecting the skeletal muscles and contributing to postural changes and difficulty in movement. Speech becomes low in tone, monotonous sounding, and slow. Enunciation becomes difficult due to the decreased dopamine and the excitatory response from the increased acetylcholine. PD usually does not affect intellect. However, a percentage of patients will develop a dementia similar to that of Alzheimer's disease. Stress will tend to make symptoms worse. The characteristic symptoms of the disease are used to diagnose the disorder. An MRI of the brain can be formed to rule out any other neurologic disorders. Treatment of PD typically includes drug therapy, physical therapy, and considerable emotional support. Anticholinergics, dopamine agonists, and MAOIs are used to control symptoms. Deep brain stimulation is a surgical procedure that can be used to treat many of the neurologic debilitating symptoms associated with PD. On page 569 in the red safety alert box, you can read about caution when administering MAOIs. Stereotactic neurosurgery may be performed for implantation of DBS devices if drug therapy fails to relieve a patient's PD symptoms. DBS uses electrode implants to provide electrical stimulation that controls tremors by blocking them. There has been considerable success with DBS, but it is expensive, approximately $65,000 for the implant unit and surgery. Depression is common among patients with PD, but most respond well to a selective serotonin reuptake inhibitor antidepressant. Dysphagia may develop, and mobility becomes severely limited as the disease progresses. Constipation, urinary incontinence, and insomnia are also common. Nursing care focuses on preventing complications of PD, drug therapy, enhancing voluntary movement, and safety. Grasping coins or other objects could help decrease tremors because it is an intentional action. Teach the patient to consciously assume correct posture. Learning to sleep prone is also beneficial for posture correction. Remember that patients with PD need extra time to finish tasks. Considerable patience and understanding are necessary to help the patient cope with the frustration of deteriorating body control and inability to do things that they formerly could do easily. Falls are common, and safety is a major factor. Using a cane or walker will increase stability and decrease the incidence of falls. Grab bars should be installed in the shower and tub. A raised toilet seat should also be installed. Multiple sclerosis, or MS, is a chronic inflammatory disease that causes demyelination in the central nervous system. The most common type of MS is characterized by periods of remission and exacerbation. The most common type of MS is relapsing remitting. The cause of MS is not known, but the most widely accepted theory is that it begins as an inflammatory immune-mediated disorder. The inflammation may be a response to an environmental factor combined with a genetic predisposition for the disease. MS is considered an autoimmune disease in which the immune system attacks healthy CNS tissue. There is no cure. Symptoms typically appear between 20 and 50 years of age, but they can occur at any age. A genetic factor can be involved, and the disease is sometimes seen in more than one family member. Myelin is a protective sheath that insulates axons and assists with impulse transmission. In patients with MS, plaques form along the myelin sheath, causing inflammation. When myelin is eroded by inflammation and replaced by scar tissue, known as demyelination, nerve impulses can no longer travel along the damaged neurons. There are 4 clinical progressions of MS, and these can be seen in Table 24.2. On page 574. MS follows a course of unpredictable flare-ups that are followed by periods of partial or complete remission. Because the disease can affect any CNS tissue, symptoms can be unpredictable and vary from person to person. The more common manifestations of MS are as follows: motor dysfunction, sensory dysfunction, problems of coordination, mental changes, fatigue, and additional problems that would occur later in the disease are related to urinary and bowel incontinence as well as altered sexual function. No laboratory test will definitively establish a diagnosis of MS, although most patients have elevated IgG levels in their CSF and oligoclonal bodies. An MRI study usually will show characteristic white matter lesions scattered throughout the spinal cord and/or brain, which confirms the diagnosis of MS. However, the clinical signs and symptoms presented by a patient are typically sufficient to allow the neurologist to make the diagnosis that the patient possibly has MS. Treatments fall into 2 categories: those that prevent attacks or modify the disease process, and those that treat the symptoms of the disease. There has been an enormous amount of success with treatment from biological response modifier drugs like interferon beta 1b, which is effective for many ambulatory patients with relapsing remitting MS. It is given by injection and reduces MS attacks by 1/3, as well as decreases the number of severe attacks. Acute attacks will be treated with IV methylprednisone for 5 days, followed by oral prednisone in tapering doses. Most therapeutic efforts are centered on supportive measures to maintain resistance to infection, reduce muscle spasticity, and manage specific symptoms like diplopia, speech disorders, muscle weakness, fatigue, and depression. An exercise program is very beneficial for patients with MS to relieve spasticity and improve coordination. Swimming provides considerable benefits because exercising in water is less fatiguing than exercising out of water. The patient should be provided with the support and physical and psychological means necessary to develop a positive and hopeful outlook. Antidepressants may be helpful. Disease-modifying agents can reduce disease activity, frequency of relapses, and possibly progression of MS. Testing extremity strength, looking for visual problems, and checking reflexes are all part of the physical examination. Appropriate care for a patient with MS depends on the severity of the disease and the symptoms. During the diagnostic phase, the patient and family need a great deal of emotional support as they realize that MS is a chronic disease and there is no cure. The patient should not be exposed to excessive heat or hot baths, which could cause weakness to become much worse. Help the patient and family establish a consistent daily routine that will promote optimum levels of functioning for the patient. The routine should include daily physical exercise balanced by rest periods to prevent fatigue. Patient teaching involves education about the unpredictability of the disease and the need to prevent stress, infections, and fatigue, as well as a referral to the National Multiple Sclerosis Society and local support groups. Alzheimer's disease, a form of dementia caused by pathologic changes in the brain tissue of the patient. Diagnosis is made by history and examination because the specific diagnostic changes can be detected only at autopsy. This disease has a slow onset, progresses at varying rates of speed through several stages, and is eventually fatal. Amyotrophic lateral sclerosis, or ALS, is or known as motor neuron disease, also known as Lou Gehrig's disease, is a progressive neuromuscular disease characterized by degeneration of the gray matter in the anterior horns of the spinal cord and the lower cranial nerves. ALS is classified as being either familial or sporadic of unknown origin. One of the first clinical manifestations of ALS is weakness of the voluntary muscles, especially the distal muscles of the extremities. As the disease progresses, there is atrophy of the muscles. Only the motor neurons are affected in ALS. Therefore, the patient remains mentally alert and does not have sensory impairment. Death typically results from respiratory infection and dysfunction, as weakness and atrophy of the respiratory muscles impede normal respiration and mechanisms to clear bacteria and secretions from the lungs. There is no laboratory test to confirm a diagnosis of ALS. There is no cure for ALS. Non-invasive ventilation can extend life and delay the need for an artificial airway. Eventually, impaired breathing will require a tracheostomy and mechanical ventilation. As the disease progresses, periodic assessments can identify specific needs. While still able to function, the patient should make their wishes known to their family and healthcare provider. Rehabilitation includes obtaining equipment and devices like a walker, wheelchair, hospital bed, suction machine, and NG or gastrostomy tube feeding supplies. Because of the nature of the disease, the patient and family will experience issues related to terminal illness, death, and the grieving process. Towards the end of life, the services of a visiting nurse or hospice program could provide appropriate instruction and physical and emotional support. Encourage patients to talk with their family about any desires they have for their funeral. Make sure that the advance directives are available to caregivers. Guillain-Barré syndrome is one of several relatively rare immune-mediated polyneuropathy diseases that affects the peripheral nervous system, especially the spinal nerves outside the spinal cord. It can also affect the cranial nerves. The cause of GBS is not known, but it usually follows a simple viral respiratory infection or gastroenteritis in adults within 2 to 4 weeks. Some immunizations, surgery, trauma, and bone marrow transplantations are considered possible triggers. Cytomegalovirus and Epstein-Barr virus are two viruses that have been linked to GBS. Pathologic changes include demyelination, inflammation, edema, nerve root compression. These changes will bring about paresthesia, pain, and progressive ascending paralysis that is typical of the syndrome. Objective and subjective symptoms of GBS include mild sensations of numbness and tingling in the feet and hands, followed by muscle pain, tenderness, and aching, especially in the shoulder, pelvis, and thighs. There is progressive muscle weakness, typically starting in the lower extremities and moving upward over 24 to 72 hours. Pain is common and may be evidenced as a paresthesia, muscle aches and cramps, as well as a hyperesthesia. This is an abnormal sensitivity to stimuli. Diagnosing GBS is difficult because its characteristic signs and symptoms are similar to those of several other diseases. Medical treatment is mainly supportive. The use of IV immune globulin or IVIG to hasten recovery can also be effective. Most patients with GBS recover and walk independently at 6 months, with full motor recovery within 1 year. Assessment is the most important aspect of care during the acute stage. Observe vital sign trends and watch for orthostatic hypotension and cardiac dysrhythmias, which could indicate the degree of autonomic system dysfunction. There are 3 phases of GBS: the acute phase, the static phase, and the rehabilitation phase. During the acute phase, the goals are to sustain life, prevent complications related to immobility, promote rest, and comfort. Vital signs must be checked frequently. Cardiac arrhythmias are common, and the patient should be continuously monitored. The paralysis and loss of control that occur with GBS will come on so suddenly, and they are so overwhelming that the patient will become frightened. The static phase is a kind of plateau in which the patient reaches 1 to 3 weeks after the onset of illness. This phase can last from a few days to months. During the static phase, nursing care is concentrated on preventing complications of immobility and helping the patient deal with feelings of anger, depression, and anxiety. There must be a balance of rest and exercise, and no sudden changes in posture or position in case blood pressure suddenly drops. Meticulous skin care is essential due to immobility. The final phase, rehabilitation, is one of gradual recovery. As muscle function returns, the level of exercise and activity is slowly increased. Approximately 80 to 90% of patients have little residual deficit. Poliomyelitis destroys the motor cells of the anterior horn of the spinal cord, the brainstem, and the motor strip located in the frontal lobe. It is caused by a virus and can be prevented by immunization with the Salk or Sabin polio vaccine. A new onset of weakness, pain, and fatigue may occur in people who have had the disease more than 30 years ago. Disability could be temporary or permanent. Treatment is geared towards making lifestyle modifications to preserve energy and physiologic function. Huntington disease, or Huntington chorea, is a rare genetically transmitted degenerative neurological disorder characterized by abnormal movements. Signs of Huntington disease usually become evident during the 4th or 5th decade of life, but they may occur earlier. This disorder is progressive and causes disability and then death within 15 to 25 years after signs appear. Death is from neurologic degeneration affecting all body systems. It is an autosomal dominant disorder, meaning that the children of a person who has the disease has a 50% chance of inheriting it. If a child does not inherit the disease, the gene is not passed on to the next generation. A person with Huntington disease progresses from being fidgety and restless to a state of constant movement, chorea. Intellectual decline causes depression, suspiciousness, and eventual dementia. There is no known treatment to alter its course, but therapies can be used to manage its symptoms. Myasthenia gravis literally means grave muscle weakness. This disease is a chronic disorder. It involves skeletal muscles, respiratory muscles, and muscles innervated by cranial nerves. In 15% of MG cases, the weakness is localized to the muscles of the eye and is called ocular MG. Patients with weakness in all muscles have generalized MG. Myasthenia gravis is an autoimmune disease in which T-cell dependent immune attack is directed against the postsynaptic acetylcholine receptors at the neuromuscular junction. Symptoms of MG include diplopia, difficulty chewing and swallowing, and ptosis. The patient's voice tends to be hoarse or nasal in quality, and voice volume decreases towards the end of a sentence. Severe muscle weakness that improves with rest is the primary symptom of the disorder. Ocular MG may occur first and be demonstrated by diplopia and ptosis. If cranial nerves become more involved, bulbar myasthenia occurs, with facial and oropharyngeal muscle weakness, causing a blank facial expression and a smile resembling a snarl. Swallowing and speaking become difficult. The disease does not affect the level of consciousness. Muscles are strongest in the morning and become weaker with activity. Respiratory muscle weakness may require mechanical ventilation. Diagnosis is established by history and physical examination, with confirmation from laboratory and electrodiagnostic testing. Electrodiagnostic testing is performed to check muscle function. There are two main modes of therapy: managing the disease by treating the specific symptoms, and managing the underlying cause of symptoms by inducing remission. Because 80 to 90% of patients with MG have autoantibodies against acetylcholine receptors, plasmapheresis can be an effective treatment for patients in crisis. This mode of therapy may bring about clinical improvement in some patients, but it is not a cure for MG. Anticholinesterase therapy is the primary treatment for MG. Excuse me. Anticholinesterase agents temporarily increase muscle strength by allowing acetylcholine to work, but they do not cure the problem. Two drugs commonly used as anticholinesterase agents are neostigmine and pyridostigmine. IVIG infusion is sometimes prescribed. Stress can quickly alter a patient's need for acetylcholine. Hence, overmedication or undermedication can occur rather suddenly. Another method of treatment is to remove the thymus gland, which decreases the antibody production. Treatment with IVIG for 5 days can produce a favorable response for 30 to 60 days. The severity of MG is assessed by asking about the degree of fatigue, what body parts are affected, and how severe the problem is. Assessment of respiratory function is a top priority. Assess muscle strength of the face, swallowing, speech volume and clarity, and cough and gag reflexes. Check the strength of the shoulder muscles and of the limbs. Infection, surgery, and other physical and emotional stresses can precipitate a myasthenic crisis and cause hospitalization. Suctioning, intubation, and mechanical ventilation may be necessary to maintain life until the crisis is over. Education of the patient and family must include instruction about the nature of the illness and the adverse effects of the emotional upsets, respiratory infections, and similar stresses. Rehabilitation goals include education and support for the patient and family so that the patient remains as independent as possible. Because patients with MG can become critically ill and need immediate medical attention at any time, they should at all times wear a medical alert emblem that identifies that they have the disease. The patient, as well as members of the family and nurses who care for them in the hospital or at home, should know the symptoms of overdosage of anticholinesterase medications, as well as the symptoms of a myasthenic crisis caused by underdosage of anticholinesterase agents, a precipitating illness, or other stress factors. Always check each drug the patient is on to look for interactions and contraindications. Restless leg syndrome, or Willis-Ekbom disease, is a sensory motor disorder that may affect up to 15% of the population, and women are more often affected than men. It is marked by an uncontrollable urge to move the legs or arms, more often in the evening, and its cause is unknown. However, there does appear to be an underlying genetic component. RLS is classified as primary if no family history or other explanation is found as secondary, and if they have a condition known to be linked to RLS. Patients with RLS typically have low iron levels, and iron replacement therapy is indicated. Non-pharmacologic therapies include exercise, avoidance of aggravating factors, leg massage, and decreasing caffeine intake. Drug therapies include pramipexole, ropinirole, and rotigotine transdermal patch, which are all dopamine agonists. You should foster an encouraging environment and provide education about the syndrome. After leaving the hospital, patients with neurologic problems often are cared for in long-term care facilities, rehabilitation programs, outpatient clinics, and the home. Nurses who work with these patients who have neurologic deficits that cause some degree of immobility must constantly try to prevent the complications of immobility and try to achieve as high a level of function for their patients as possible. Because older adult patients often have more than one chronic health illness, it is essential that nurses be knowledgeable about medication interactions and side effects. A close working relationship with the pharmacist can assist you in judging these matters. Home care nurses interact with the entire family and need to continually offer support as the difficulties of learning to live with someone who has a neurologic deficit are faced daily. Referral to a community support group is often helpful for both the patient and family members.